Good afternoon, everybody. My name is Dr. Moira Thomas. I'm a consultant immunologist in Glasgow. Thank you so much for joining us for today's webinar from the RC Path. It's entitled Hereditary Angioedema, Pathophysiology, Drug Targets, and Update on Management. So this webinar is due to run for approximately an hour, and there'll include a presentation followed by a Q&A. And if you would like to ask a Q&A, please do use the Q&A function at the bottom of the screen. This webinar is going to be recorded and uploaded to the RC Path website in the coming weeks, and you can self-accredit for 1 CPD point for attending today's webinar. Now, we have one speaker today, and I'm delighted to introduce Dr. Serena Kiani. Dr. Kiani is a fellow of the RC Path and Royal College of Physicians in London. He is a consultant in allergy and immunology at the Royal Free in London, and he studied medicine as part of UCL's medical school MB PhD program in with his PhD being in immunology. And he undertook his specialist training in allergy and clinical immunology in London before becoming a consultant. And he is a principal chief investigator in a number of studies on HAE. And a key bit of information he left out is that he started as part of his medical career in Dundee in Scotland. So welcome, Serena. Please do start.
Thank you, Moira. I'm going to try and share my screen now so I could get started. So can you just tell me whether you can see my screen, and then I'll start?
I can see your screen.
Okay, great. Okay, so I'm Serena Kiani, as Moira said, consultant immunologist at Royal Free in London. This is the title of the talk: Hereditary Angioedema, Pathophysiology, Drug Targets, and Update on Management. So the target of the talk, the target audience is, at the beginning of the talk, is going to be general physicians, GPs, or emergency trainees, but later it becomes more specialist and more targeted to allergy and immunologists who see patients with angioedema. So first of all, what is angioedema? And angioedema is localized swelling, which can happen in the deeper tissues. So the actual fluid extravasation is in deeper tissues, as opposed to edema, which is pitting and is more on more superficial layers of the skin. It can occur at any part of the body, including the bowel, and bowel angioedema can be very painful. In certain types of angioedema, you can have bowel angioedema. So this is for the general physicians or people who've not really seen many patients with angioedema. The first thing that one needs to think about is whether there is a rash or there isn't a rash. So as I said, I'm going to start with this basic stuff on angioedema, then we will go into classification of different types of angioedema, then we'll focus on one type of angioedema and the clinical trial results on those, and the current recommended treatments by various guidelines. So angioedema with rash is more common than angioedema without rash, and often is with urticaria, which is a well-demarcated erythematous, itchy, sometimes burning sensation rash, which is basically elevated and not flat on the skin. But sometimes you can get angioedema with erythema, and sometimes because people haven't actually noticed the elevation, which makes it into urticaria. But this is a well-known phenomenon, angioedema with urticaria. This type of angioedema is as a result of activity of mast cells and degranulation. So it's histamine mediated mainly, and also the other granules which are released probably have some role in it. There could be different reasons for it. It's either IgE mediated, which is basically some form of allergy, sensitization to some allergen, and as a result of that, you have mast cell degranulation, or it's not Ig mediated and it's direct mast cell degranulation for a variety of reasons. We now know that there are specific receptors, for example, for drugs that can cause this, or it could be as a result of some sort of physical stimulus that we still don't quite understand why the inducible or physical urticarias could be as a result of cold, pressure, vibration, or it could be associated with some sort of infection or fever. What's important to remember about this, on the whole, they're antihistamine responsive. Now, angioedema with no urticaria, which is the main subject of this talk, has different features. It usually takes a bit longer to come to its maximum peak and to resolve than the histamine-mediated angioedema. It goes through flares, like almost has flares that people can have periods of increased activity. Could be precipitated by mental and physical stress, and that's been shown in various studies. And this is the same with angioedema with urticaria as well, but this particularly in this condition has been shown. It's not responsive to antihistamines or adrenaline, and that's the most important thing to remember for this type of angioedema. But here I have to say that there are certain angioedemas with no urticaria or with no rash, which are also histamine mediated or maybe mast cell mediated, and they do respond to antihistamines, and we'll come to that in a minute. But this is just the rule of thumb. So here I've got a classification actually for angioedema with no urticaria or with no rash, and I'm going to actually show it to you in this diagram, which is probably a bit clearer. It distinguishes different types. So we could divide them into hereditary, acquired, or some without known what inheritance. We don't know what the inheritance is. So the hereditary ones are two types. One is because of a defect in a protein called C1 inhibitor, and we'll talk about that in a minute. And that could be two different types. One is that C1 inhibitor levels are low, and one C1 inhibitor levels are normal, but it doesn't function. There is another type, which is HAE-NC1-INH, they call it now, or C1 inhibitor normal HAE. And previously, people used to call it type 3, but that shouldn't be called type 3 any longer based on the latest classifications. We are finding more and more mutations which can cause that, and we'll talk about what pathway these mutations are in. But if you look at this factor 12, angiopoietin-1 plasminogen, there are some other ones which I will mention later on. And then you have an acquired form, and acquired forms you have either due to drugs, and the most common one that we all know about probably is the ACE inhibitor-induced angioedema, but we are finding more and more with new drugs such as diabetic or DPP-4 inhibitors. Both ACE inhibitors and DPP-4 inhibitors increase the availability of a certain substance which causes this type of angioedema, and in the next few slides I'll talk about that, which is called bradykinin. Or estrogens can precipitate, or even now we find in some patients whose angioedema may be precipitated by ARBs, and this could be years after starting ACE inhibitors, not just immediately after, because it's not an allergic reaction in a classic form that we know about. It's not Ig mediated. Or streptokinase is another drug that can cause this. The other acquired forms are paraproteins, and maybe they are interfering with C1 inhibitor. And the other one is hematological malignancies. And as I said, there are some with unknown inheritance, and maybe they're the same as HAE with normal C1, but we don't, and maybe there's a genetic cause behind them, but because they don't run in families, we don't actually put them in that category. So just a quick basic of how this type of angio, or majority of this angioedema occurs. The ones that we know are caused by a certain defect. So as I said, angioedema is basically extravasation of fluid under the deep layers of the skin. And this occurs in certain or a large group of people, or at least in people with HAE type 1 and 2, and many people who have C1 normal HAE, or people who actually, we don't know what their inheritance pattern is. It could be because of something called bradykinin, which is a short peptide with a very short half-life. it causes gap junction opening in endothelial layers of blood vessels and extravasation of fluid, which causes angioedema. If we look a bit more detail where bradykinin comes from, it comes from a large molecule called high molecular weight kininogen, two enzymes, factor 12 of intrinsic coagulation and kallikrein, come together, and they, I'm going backwards here, and they basically catalyze the sort of enzymatic cleavage of bradykinin from high molecular weight kininogen, which then binds bradykinin receptor 2. There are two receptors for bradykinin, but it's the bradykinin receptor 2, or B2R, then results in gap junction opening and extravasation of fluid. Now, what controls, one of the main controls of this activity is the enzyme C1 inhibitor, which I talked about, and I'll be talking in more details. So this blocks this activity. And when we have a defect in C1 inhibitor, you can actually have angioedema caused by bradykinin or bradykinin-mediated angioedema. There are other mediators, other reasons for increased bradykinin, as we talked about a little bit earlier, which was, for example, drugs such as DPP4 or ACE inhibitor that increase the availability of bradykinin. But there'll be other elements that I will talk about. So to just put this in context, where is this pathway? This is actually in top right hand side here, you could see is the kinin kallikrein system. And kinin kallikrein system is part of the whole thing called contact system. If I show you more, the contact system consists of kinin kallikrein system, which is involved in blood pressure control, coagulation cascade. We know what it does. It's involved in blood clot formation, the opposite fibrinolytic system in breakdown of clots, and the complement system, which is a primitive form of innate immunity, which detects and also fights infections. As one of the jobs it does. It also signals, produces signals of warning signals to the rest of the immune system. So kinin kallikrein system, to look in more details, this is the same really picture of contact system. You have here plasma PK or plasma kallikrein, which basically comes together with factor 12, activated factor 12, as I said in that diagram before. They break down high molecular weight kininogen into bradykinin, and then there's the cleaved product, which we haven't got here. So then this bradykinin acts on its receptor to cause extravasation of fluid. So we'll come back to this diagram later to show you the targets on this system that have been used for therapeutic purposes. And what I can say is that a lot of the genes discovered to be involved in C1 normal inhibitor, this is the C1, which inhibits this function as we talked about, and inhibits this activity and also complements C1. So a lot of angioedema, which are not due to C1 inhibitor, have been found to be from something to do with here, for example, factor 12, the most common one. So let's move on to the next one. So let's talk about C1 inhibitor. This is a protein which is on the gene SERPING1 on chromosome 11. It's inherited as an autosomal dominant inheritance, so 50% of children and family have the chance of or risk of having it, and there's no male-female separation or racial separation. It's a SERPIN protease, and it's actually a what they call suicide enzyme, which basically only facilitates one single reaction, and then after that it's destroyed. So it's used up usually. And as I said before, those are the where it irreversibly inactivates these proteases that I've put down there and I talked about earlier. So as I said, there's no sex or age difference. It's rare. It's found in 1 in 25,000 to 1 in 50,000 individuals. Majority of them don't have normal levels of C1 inhibitor, 85%. So as a result of that, there is also low function when you test these patients. So you test levels and function, and this is what you get. Now, type 2 are minority of people, and they have basically normal protein levels, but not normal function. So The other type that we talked about, C1 inhibitor normal, is very rare. The most common was factor 12. Angiopoietin 1 and plasminogen have also been identified, and there are a few other genes identified, which we'll talk about. The factor 12 one is mostly in women. Only 1 or 2 men have been discovered, and to have this condition is a probable gain of function and might be different other mechanisms. And it's basically becomes apparent when during sort of puberty, or if I had a patient, for example, from Japan who didn't have any swellings until age of 22 when they started on contraceptive pill, and then they were discovered to have factor 12 deficient or factor 12 gain of function, whatever we want to call it. So the other type, acquired angioedema, which we talked about earlier, normally in older age group, it's absent family history, can be associated with paraprotein, but not always, because it can be found in lymphoproliferative disease without paraprotein, particularly marginal zone lymphomas. And treatment of the lymphoma usually treats the condition, but mostly marginal zones are not treated. So we're left with having to treat the angioedema. And sometimes there are antibodies or maybe even the paraprotein, which is against C1 inhibitor. Okay, so let's move on to some clinical sort of definitions, really. Here is, I put a paper. There are about 3 or 4 papers like this. It looks at burden of at least 3 or 4 papers, but recent ones, I mean. Look at the burden of this disease. This paper is international. It's Canada, Australia, Europe, including UK. But there is a purely American paper as well, and there are various other papers. There was a paper actually written from the UK by one of our colleagues a few years ago. Steve Jollis did a paper similar to this to look at the burden of disease. Patrick Young led doing another paper recently. They all tell the same thing, but this one had the most colorful pictures, so I thought I'll show it to you. Here, you could see here, this is, looking at these patients, with 242 patients, and they asked them about the number of attacks in the last 6 months. Graph A is top left-hand side. And you see only 2.9% of them had no attacks. So they commonly have attacks, and some of these people are on treatment, some of them are not on treatment, but we're talking about preventative or prophylactic treatment. And you look at on the right hand side, you can see again, it shows here the number of people who have not had an attack more than 12 months or even more than 7 to 8 months is very few. So people have a lot of attacks. If you look at the graph D on the bottom right hand side, you can see the attacks could be anywhere again, the trunk, extremities, face, throat and mouth. This is to look at the type of symptoms they have when they have their attacks. Apart from swelling, there's tiredness, there is nausea, diarrhea, difficulty swallowing, difficulty breathing if it's the throat. So pretty nasty. And you can see mild, moderate, and severe. There are a significant number of people who have severe swellings, but even mild ones can be quite debilitating. And often people, so mild is sort of defined as they are able to get on with their day, but they have pain and they remember they have this, but they've got used to it, a lot of them. Here, there is basically quality of life studies, and there isn't much of a trend here, but what's interesting, there is depression and anxiety, probably more than general public. But what I find interesting in this graph is that even people with 0 attack are really worried. And the reason they're really worried is that often these people have a family history of grandparents who died of asphyxiation from this disease. This disease comes from nowhere. You don't know when you're going to have your next attack. So it's very difficult to, in some ways, feel confident and organize your life if you're not on good treatment. And until very recently, there weren't any good treatments. So I'm just going to show you the history, actually, of what we know, this about treatment as well as the disease. So it was first actually described as hereditary angioneurotic edema in 1888. We don't call it angioneurotic edema, but we still have some referrals in angioneurotic edema. So it's not that long ago, but it's long enough. And if you look at the mechanism, discovering what the pathology was, it was first thought that it was autosomal dominant in 1917. Then it was found to be basically C1 esterase inhibitor discovery was in 1961, but they didn't think that was the cause, the defect of that. 1962, it was shown that kallikrein levels were low, and then Donaldson and Evans in 1963 showed that it was absence of C1 esterase inhibitor in type 1 HAE was the cause. In terms of treatment, initially testosterone, methotrexate was the only thing, and then fresh frozen plasma for acute attacks because it contained C1 inhibitor in 1969. Later tranexamic acid was used, and in the late 1970s, C1 inhibitor concentrate was produced. Just to say also, attenuated androgens have been used and are still used, and probably the most common thing that used for hereditary angioedema. I'm not really going into that. I've given enough talks about the potential side effects of these drugs. Here, in terms of treatment, in 1971, C1 inhibitor concentrate was used in Europe, but it wasn't used in the United States till this century, really. Bradykinin receptor antagonist was used for acute treatment in 2008 in Europe. Ruconest, 2011, Ruconest is a C1 inhibitor, recombinant C1 inhibitor. And then lanadelumab and berotralstat, a monoclonal antibody, lanadelumab and berotralstat, oral inhibitors of kallikrein were used in 2018 and 2021. So as you can see, the treatments really started coming in 2008 or so. Back to the contact system and the pathology, and so I put this up to say that, as I said, first of all, hereditary angioedema is as a result of C1 inhibitor defect, type 1 and 2. The one with that C1 inhibitor defect, there are some targets here which might be the cause, but we're going to focus now on treatment of C1 inhibitor deficiency or hereditary angioedema type 1 and 2, which is the most common form. So these are the drugs which are available currently. So starting from down below here, you see Ruconest, as I said, the recombinant form of C1, Cinryze and Berinet. These are plasma concentrates from donations. They replace C1 inhibitor, can be used for acute treatment and for prophylaxis. Here we have attenuated androgens. We don't know exactly how they work because they're very non-specific, and they have probably target every cell in the body, and also proportionally have as much side effects. Some of them quite hidden and not obvious, but can happen over a long time, and there's enough studies to show that. Then if we go up here, top right hand side, we have icatibant, which is an injection, a subcutaneous injection for acute treatment only, and it's a bradykinin receptor 2 antagonist, and I will talk about the clinical trials for these in a minute. Ecallantide is another sort of acute treatment as an injection, which is again kallikrein inhibitor, but we don't use it in Europe or United Kingdom. It's only used in US. There was a lot of anaphylactic reactions to it. That's why it wasn't ever brought here. Then you have lanadelumab, which is a monoclonal antibody, which came in 2018, as I said, and it's the target again is kallikrein. And then the first oral treatment against the same target is berotralstat. And tranexamic acid here has been there forever. Doesn't work very well for most people. There are a few people who do respond to it, and that's basically works on the fibrinolytic pathway, the plasmin, and there are theories about why it works. It does work in some people with C1 normal angioedema, for example, particularly the ones with plasmin mutations. Okay, so now I'm going to show you new targets that have been used and they're in development. As you can see here, there is anti-factor 12 or garadacimab. The CSL312 was the name of it when it was still a sort of an IMP, investigational medicinal product, that works on factor 12 to block this enzymatic activity. Next thing is deucrictibant, which is actually, you could say, is oral icatibant. It's exactly the same as icatibant, almost works on the bradykinin receptor 2, and it can be used for treatment of acute attacks, but can also be used for, and this is not available yet, by the way, the drugs I'm showing you now, from fact the garadacimab to the end of this slide, are all in different stages of development. Deucrictibant can be used both for treatment of acute angioedema or as prophylaxis, and the clinical trials are ongoing, and I'll talk about them in a minute. Then you have donidalorsen, which is basically targets kallikrein mRNA, so reduces kallikrein levels, and it's a monthly injection. Then you have STAR-0215, which is a monoclonal antibody, very similar in some ways. The target-wise, I don't know whether exactly the same epitopes, but it targets kallikrein. But the difference is that it has a longer half-life, whereas lanadelumab can be given 2 weekly or monthly, and some people have even extended it themselves to 2 monthly at home. STAR is designed to last longer because it's got sort of glycosylation modifications, and it is meant to be injected every 3 months, and maybe they're trying to make it even longer, maybe every year. Come and get injection on your birthday and you're okay for the rest of the year. That's the future, I suppose. But at the moment, STAR has been investigated for 3 monthly injections. Then we have sebetralstat, which is an oral kallikrein inhibitor, which was in a prophylactic trial, but because there was serious adverse events in terms of liver function abnormalities, was withdrawn. And now data has come out, which I'll show you in a minute, used for treatment of acute attacks. And then finally, the gene therapy. And you can see at the top right-hand side, I've got NTLA 2002, which I'll talk about a little bit, ongoing gene therapy at the moment, which again, similar to donidalorsen, it reduces level of kallikrein or tries to abrogate kallikrein production. And then you have down here OTL-105 and biomarine vectors. These were basically using vectors to replace a total C1 inhibitor gene rather than cause a second knockout, which NTLA does. So NTLA knocks out a gene, whereas these were meant to do that, but they withdrawn them, and probably the reason for that is the fact that there are so many successful drugs now in the market, and they felt that there was no place for this. And I'll show you another reason, which I think might have been behind it later. So let's look at the acute treatment. This is a slide from Dr. Patrick Young. He let me use his slide, and thank you, Patrick, again. As he said at the top, the trial methodology not the same for all this, so it's difficult to really compare percentages. But sebetralstat, which I said was the one against kallikrein, that basically they used, they reported these values. So there are 2 different doses, and the median time to onset of symptom, which is something one needs to ask a patient. When you see a patient, if you want to get a feel for their angioedema, one is to do AECT scores, which is a validated tool, and it takes about less than a minute to do. And that gives you a good idea how well their disease is controlled. But you can also ask questions about, so, number of attacks, severity of attacks, so on and so forth. But how long does it take for you to respond to treatment, start responding to treatment, and then how long does it take for you to go completely back to normal? What they reported was 2 values for different doses, 1.6 and 1.7 hours versus placebo, which was 6.72 hours. And in terms of complete resolution within 24 hours, they didn't say how many hours it takes for resolution. It said 42.5 or 49.5% had complete resolution. So about half people with the best dose had complete resolution within 24 hours, compared to 27.4, nearly 30% placebo. So not much better than placebo, really. And there was no significant safety signals, they said. The other one, deucrictibant, which is similar to icatibant. Icatibant I've got at the end. Their trials were done many years ago. They showed a median time to onset of symptoms 2.4 versus 8 hours. So it took a bit longer for people to actually notice symptom relief in this study, but their placebo seemed to be a bit longer as well. So maybe patients had more severe disease, or their placebo wasn't good enough. And then they have medium time to almost complete or complete symptom relief or complete resolution was very good, 7.5 hours versus 42 hours for placebo. So you can see very, good. And that's quite comparable, even a bit better than icatibant, because icatibant is the same molecule injected. The median time to almost complete symptom relief is 8 versus 36 for icatibant. And that's the interesting thing about deucrictibant, which is absorption is very fast, and you could actually see optimal levels in patient bloods almost as quick as, or even maybe quicker than icatibant. So that's something to look at for acute treatment. Now, these are long-term prophylaxis in terms of comparison. Again, methodology wasn't the same. You've got lanadelumab, berotralstat, garadacimab. Most of these, the injectable ones, have very similar for prophylaxis, similar percentage reduction in attack compared with placebo. You have deucrictibant, which has a very good reduction in attack compared to placebo, even though it's oral. Berotralstat is 44%, but we are allowed to use berotralstat in the UK for patients with 2 attacks per month or more. And as they say, proof of the pudding is eating it. So we've had a look at both lanadelumab and berotralstat in real world, and these are published in Journal of Allergy. So this was led by Dr. Manisha Ahuja, who's a registrar in Newcastle and doing her PhD at the moment. And what we found that, it was after 3 months and 6 months, there was a reduction in percentage of attacks by about 52%, and after 6 months, 65% roughly in percentage. So it was a bit better than the actual clinical trials. This was about 54 patients in multiple centers in the UK. And I will put up name of my colleagues who helped with this study at the end. It also showed improvement in the ACT score, and also overall severity was reduced. And something, you look at all clinical trials for prophylaxis, it seems to be they get better and better with time, as if you create a certain equilibrium in the contact system, that as time goes by, the efficacy improves. So we didn't look after 6 months then, but I know a lot of you have sent in data now for follow-up data. So we're going to look at further time points, which will be really interesting to see. And then here is the same sort of study done, but with this, for lanadelumab, and Dr. Anthony Dorr, who's now consultant at Barts Health, he led this study. And you can see this was after 6 months and 12 months. There was, as you can see, there's still improvement from 6 months to 12 months, from 87 to 93%. And we are allowed in the UK to use this for patients with 2 or more attacks per week, which is something like 8 attacks per month, quite a lot of attacks. Now, just a brief, because a lot of patients have asked, and also doctors are asking about, whether HAE can be cured now because of this gene therapy. And this is very exciting gene therapy, which is CRISPR-Cas9, which knocks out KLKB1, or basically prekallikrein, and reduces kallikrein. There is an equivalent disease to that, which is called Fletcher factor deficiency. The data release for this has happened, and it looks like pretty good response and also safety pretty good. But this is short term. And if you look at this paper, which was written in 2020, I'm sorry, I haven't got JTH. They looked at, I mean, prior to that, this is a rare disease, the Fletcher factor deficiency or knocked out kallikrein. It's a rare disease, so people didn't know much about it. And the clinical trials actually started a year or two before this paper came out. But they looked at this paper. Again, thanks, Patrick, for this slide. This slide shows the paper was looked at 111 patients around the world with this condition, which was there was increased level of major bleeding and cardiovascular events. So they concluded that any trials on plasma kallikrein inhibitors should include cardiovascular events as a safety outcome, as the prevalence was not negligible in individuals with severe PK deficiency. So basically, this is sort of gene therapy is probably the future, but there are a lot of treatments available for angioedema now, and it's a bit difficult to think about actually what is the long-term effect of knocking out a second gene in a patient with HAE. But the trials are happening now, and we'll no doubt see over a long time. So this is again the gene manipulation, and again Patrick's slide. What I found really interesting, this was Patrick saw this talk in EARCI 2024, where basically a Belgian economist came and health economist came and talked about the cost of HAE, and this is a cost of just drugs and no other additional cost, which is a huge amount of additional cost. But if you just look at the cost of drugs, it was something like £40,000 per patient per year. And if you basically cost of HAE, discounted cost of healthcare for HAE costs about 260 to 425,000 euros, not pounds, sorry. And then they looked at pre-implantation genetic diagnosis for HAE, which can be done now, and that's much less than that, and actually prevents development of HAE rather than trying to, treat HAE or do genetic manipulation of children or adults with HAE. And I'm sure, there are many parents who would say, I'd rather not have a child with HAE than have one that would have to give treatment all the time or treat with something we don't really know what the long-term effect is. But then equally, there are many people who would not actually consent to pre-implantation genetic diagnosis, which is also understandable because of their beliefs. So finally, or not finally, I've got one more slide after this. I'm going to just talk a little bit about the latest International World Allergy Organization EARCI guidelines on HAE, and what just see what time it is to see how much of this I can talk about. Okay, we've got plenty of time. So this guideline was international guideline written by some, I don't know, 30 odd experts or authors from around the world, South America, Asia, everywhere. And this is the consensus which they came up with. I've divided it into 4 domains. It's an easy way of sort of getting your head around the guidelines and remembering them. One is diagnosis. What do you do for acute attacks? What do you do for short-term prophylaxis and long-term prophylaxis? So in terms of diagnosis, I don't quite agree with this, even though I'm one of the authors, but then, many people wanted it this way. So they said you have to measure C1 inhibitor levels and function and C4. And that's fine so far. And they said repeat above if abnormal. And I agree with all of that. But we published a paper in General Pathology, which basically we showed that at Bart's Health, with the help of my colleagues there in the lab, we showed that C1 inhibitor function measurements alone are sufficient, very accurate, and there's no need to do anything else in order to diagnose, but I would still do it twice. And actually the cheaper and less staff time depending on what systems you use. The other thing that is recommended is screen family members. If you find somebody with diagnosis of HAE, obviously screen their family members. Test children as soon as possible. In the past, they used to say wait till they're 1 year old, but nowadays they say test them as soon as possible. I'm not sure whether there's a need for cord blood testing, but after birth, maybe. And also then they say that if C1 inhibitor is normal, as a normal C1 inhibitor, then do genetic tests for that, because there are some genetic causes which have been asked, and I'll mention that in the next slide. I'll talk about C1 inhibitor normal a little bit in the next slide. For acute attacks, they're saying it's not just the drug you give patients, it's action plan. You need to give them a letter with action plan to take to A&E with them and explain everything. Specifically, make sure you say this does not respond to adrenaline or antihistamines, but also please do remember that people with HAE can also have allergic reactions. So somewhere there mention that, the patients normally know whether this is the same typical HAE swelling or not. It's more important to treat the HAE swelling. But if there are really obvious reasons that this is allergy, for example, stung by a bee and they've got a rash and they've got throat swelling, I think it's important that they give adrenaline. And yes, if it didn't work afterwards, then give your C1 inhibitor or a icatibant. And it's important to talk about the kinetics of this type of angioedema, which is slow and not normally associated with a rash, except in rare situations where people can have a prodromal erythema marginatum as their serpiginous rash, but most people don't have a rash. The guidelines say that patients should be advised to treat all upper airway attacks. You should recommend to A&E departments or emergency medicine colleagues that early intubation, surgical intervention to be considered. Patients should be looked after in an area where they can do that. They can intubate them. They can use C1 inhibitor or icatibant for acute attacks. Icalantide is for the US. We don't have it. You would recommend patients carry 2 doses of acute treatment with them, not 1 but 2 doses. And basically, C1 inhibitor in that guideline was recommended for people under 12, pregnant women, and women lactating and breastfeeding, and as opposed to icatibant, which is not licensed for that. So patients should be educated about the triggers of their attacks and how to avoid them, and also try and teach them to self-treat if possible. So all patients should be given a chance to learn that they can use acute attacks at home. And with regards to short-term prophylaxis, they basically are talking about procedures such as, for example, surgery and dental work need to be considered for short-term prophylaxis. There are other papers come out about dental work which says, more people have swellings post-dental work than it was thought in the past. So even sort of minor dental work, I think one needs to really think about it, whether, will the patient be able to administer treatment and provide them with treatment to use, or provide them with short-term prophylaxis if the procedure is more likely to cause this. And also look at the last 3 months, how the patient has been. Have they been having a lot of attacks or not? Have their attacks become more severe? So there are things like that to consider. And finally, just be safe. Give them treatment if you're not sure, because one paper shows something like 50% of attacks post dental treatment happen in the middle of the night when patients sleep, and they are usually oral, which is can extend to the throat. And the recommendation is that for short-term prophylaxis, C1 inhibitor used as first line, because other drugs have not been tested, although they may work, but it's not recommended to use them. Also, the very important thing is to think about patient-specific events. So it's not all a big procedure or some surgeon cutting a patient up that should worry you. There are things patients have done in the past and know exactly that at that time they're going to have an attack. For example, I had a patient who was a medical rep who every time he had to go and do a presentation, he would have a swelling, whereas he actually played American football nationally, and didn't get any swelling as a result of trauma. So patient-specific events should be considered and covered. In terms of long-term prophylaxis, the goal has changed from the previous guidelines. The goal isn't just to reduce, it's to normalize life, because there are enough treatment to do that. Our hands are a little bit tied here in the UK, because we can't really give long-term prophylaxis to everyone that we feel clinically needs to have it. They have to have a certain number of attacks. It doesn't even matter if they're throat swellings. It just has to be number of attacks, which is quite limited in a way of looking at patients and their experiences. It's recommended that you evaluate patients at every visit to make sure that if they need prophylaxis or not. And then you look at patients' individual disease burden as a way of deciding whether they should have prophylaxis. Uh, Numbers of attacks isn't the only parameter which determines disease burden, and different patients can cope with different numbers of attacks. Their recommendation is that there are 3 first-line treatments for prophylaxis, and they can be used interchangeably depending on patients' preferences and your clinical concentration. The C1 inhibitor, lanadelumab or berotralstat, can be used in patients interchangeably. The thing is, in the UK, as you know, lanadelumab and C1 can only be used for patients with 2 attacks per week or more, whereas berotralstat is for 2 attacks per month or more. The other thing is that they're saying attenuated androgen should only be considered as second line if nothing else is available. And then you need to review patients to monitor and adjust dose and intervals. And I personally say that monitoring patients starting on all these new medications is really essential. For example, I would always do baseline ECG when I want to start on new treatments, because I know in clinical trials people have had prolongation of QT, for example, or abnormal LFTs for all these drugs. And I would do all those, monitor them for 2-3 months, sort of closely, once a month maybe, and then monitor them every 6 months to a year later, because we're still learning about these drugs, although it seems they're pretty safe since they came out. There's another thing actually I wanted to mention, so I'm sure it's a question many people, is to do with side effects. And all these drugs have some sort of side effect profile, mostly well tolerated, but I think I'll leave it to the end. In fact, somebody might ask me and then I could answer that question about side effects. With regards to angioedema with no rash, I'm going back again. So we talked about angioedema with no rash. We just talked about hereditary angioedema type 1 and 2. Now here we talk about the ones which actually are not due to C1 inhibitor deficiency. We said you could have normal C1, and then usually the convention for writing that is HAE-NC1-INH in bracket, abbreviation for the mutation. So it could be PLG for plasminogen, ANGPTI for angiopoietin 1, and so on and so forth. Or unknown if you don't know what the mutation is, but there's a family history. Again, these are unresponsive to antihistamines and adrenaline. Now you've got INHA, or the other category, which is basically C1 is normal, they have idiopathic non-histaminergic angioedema, but there is no family history, or they don't know their family history, and this could be de novo. And if there could be a genetic reason behind it or mutation, but it could be de novo. I didn't mention this, that in hereditary angioedema type 1 and 2, C1 inhibitor deficiency can be de novo in up to 20% of people. So what's called HAE type 1 and 2, sometimes it's actually, you can't find the hereditary line, but sometimes it's because parents have such a mild disease. And what's incredible about HAE is that you can have exactly the same mutation, a brother and a sister and a mother, and I've seen patients like that, and some of them have severe disease, some don't. And whether this is environmental, epigenetics, or modifying genes, other modifying genes, all those theories apply, and people are gathering evidence for them. For example, modifying genes, they've found some modifying genes. Then we have the third type, basically, so I said the HAE normal C1, idiopathic non-histaminergic angioedema. The idiopathic non-histaminergic angioedema, or INHA, so the point how we diagnose this is that they have normal C1 inhibitor, they don't have a rash, and they don't respond to antihistamines, adrenaline. And we've basically, what we do normally practically, we put them on high dose antihistamines as recommended by various sort of respectable organizations for 3 to 4 weeks. And if they're not responding at all, then we decide that this is enough. But some of them, if you measure the bradykinin production, and there aren't any commercial, there aren't any routine tests available, but if you measure them, some of them have abnormalities in bradykinin production, increased bradykinin, or reduced breakdown of bradykinin. Now, there's another category here who basically they don't have a rash. And we don't know really what the cause is. Some of them respond to kallikrein-kinin system therapies, for example, the stuff we use for hereditary angioedema. So, must be, or you would assume these are bradykinin mediated. Some of them respond to anti-IgE therapies, such as antihistamines, even though there is no rash, no urticaria. So it's almost like chronic spontaneous angioedema, or chronic spontaneous urticaria angioedema sin urticaria. By the one anti-IgE, there are papers by Marcus Maurer, who presented a couple of years ago in EACI, and now published them, the case reports, I think about 12 patients who were in this category who didn't respond to antihistamines. There is no mention of adrenaline, but they didn't definitely respond to high-dose antihistamines, but they responded to omalizumab really well. And interestingly, a lot of these people had very high IgE. And then there are some who respond to nothing, and we still don't understand them. And that's the end of my talk. And here is acknowledgement, people who were authors of those 2 papers on betralstat real-world evidence and on lanadelumab real-world evidence. Thank you very much for listening, and I'm happy to answer any questions.
Thank you, Serena, for such a lovely, clear and interesting presentation. I think we've got about 5-10 minutes left for any questions, so please do put your questions in the Q&A. But while you're maybe thinking of that, perhaps I could ask you a question. You've told us about some exciting new drugs on the horizon. Is gene therapy for C1 inhibitor included in those, and what sort of timescales might we be looking at?
So, yeah, I mentioned one gene therapy, which is knocking out kallikrein, NTLA-2002. That's happening at the moment. And the only, as I said, reservation for that I have, and a few of my colleagues I've talked to, is the fact that it's a lifelong thing, knocking out a second gene. So you have a patient with a knockout of C1 inhibitor, you're knocking out a second gene, and we don't know what the long-term effect would be, especially people who have that gene knocked out naturally. The Fletcher factor deficient patients have now been found recently to have higher rate of bleeding and cardiovascular morbidities. So you have so many other drugs now available, to the point that people are designing drugs that you could only inject once every 3 months, or tablets that you could take when you have an attack. So one of the ideas with acute treatment with tablets is that maybe people don't like to take regular prophylactic medication, but if they can recognize their prodromes and they have a tablet that they can take and it works pretty well. And we know there are many studies come out to say that the earlier you take your treatment, the better you respond, no matter what treatment, as long as it's a real treatment and not some sort of a made-up thing. But as long as it targets kinin kallikrein system in bradykinin-mediated angioedema, the earlier you take your treatment, the better chances of treating it and not actually having any swellings. So some people know their prodromes, a lot of people do. So if you had pills that you could take immediately when you thought you were going to have an attack, then that would be a real game changer, because not everybody likes to have pills all the time. And what's interesting about that is that uh, that some people might be taking it a bit more regularly when they need it more regularly, and if they don't need it, they take it less. So what I'm trying to say, basically, there are so many amazing treatments that you don't even have to go through the pain of injecting yourself in future. And if you look at some of the data on the oral treatment, I'm a lot more excited about that than anything else, really. Um, yeah, but yes, and then there's the gene therapy, which I mentioned again. There were two programs for complete replacement of or using adenoviral vectors to introduce a normal C1 inhibitor gene. It's a very large protein, but it has been done and has been shown to actually cause, result in restoration of normal C1 inhibitor in some patients. But the programs have been abandoned, probably because it doesn't make commercial sense for them. So, one gene therapy, probably £500,000 to £1 million to do for one patient. And if you've got pre-implantation genetic diagnosis, which costs €50,000 or 25 to €50,000, depending which country you do it, then I think, many commercial companies wouldn't be interested in bringing gene therapy. And if you have drugs which are cheaper as well, lifelong, then people probably go for that. But we'll see.
Okay. We have some questions from our audience. One quick question from an anonymous attendee. How do you bridge to berotralstat in someone who's on danazol? Do you have an overlap or do you just switch?
Okay. So depending on their type of attack, so what has been happening recently, you're either switching because they're having terrible side effects from danazol and you have to stop. For example, I had a patient with massive polycythemia, which really we had to stop. Then you have no choice. You stop danazol. And if you stop danazol, you actually have to expect increased number of attacks for a period of time. And you need to prepare your patients and make sure they have acute treatment to use. The preferred option, this is how it's been licensed, is that actually you have a washout period, at least more than 2 weeks, but preferably I prefer to stop for a month before starting anything else. I've had patients, which I presented one case in Iaki this year. I had no choice because as soon as we reduced danazol or stopped danazol, they had so many attacks, they felt that they can't do it. And then even back on danazol, they were having a lot of attacks. So we agreed together that we would overlap with berotralstat, but they agreed to be monitored very closely. And I'm talking about weekly to start with liver function, full blood count, patients seen, baseline ECG, and then ask questions about if there are palpitations or anything like that to follow up. And then went to monthly attacks and monthly monitoring, and now 3 monthly. And the reason for that is that you get transaminitis post withdrawal of attenuated androgens, as these are basically anabolic steroids, and they cause, probably the reason for it is that the liver cells which are maintained by anabolic steroids suddenly start dying and you get transaminitis. But in our hand, we've seen so far it's transient. So it's very difficult to start a new drug that might also cause that when this is causes. So it's good to monitor them carefully. It's best to give a gap between the two, but prepare the patient that they're going to have attacks. The way I start berotralstat is also, I think, important to talk about, because we get very few people who talk about side effects of berotralstat. Gastrointestinal side effects have been talked about a lot. Interestingly, in the real world evidence seems to be new real world evidence will come out from a more bigger study we've done internationally, about 12%. But we do something which we follow a Berlin protocol, which actually reduces these side effects. We give it with dinner. We ask them to take it once every 3 days for 10 days, then once every 2 days for 10 days, then once a day. We prepare them that until you have it once a day for a couple of weeks, you'll not be going to be in the therapeutic range, but this way people tolerate it a lot better.
Just for a couple of questions, but we probably have to be quite brief with the
Okay.
answers. So we have an anonymous attendee asking about patients who have angioedema not responding to antihistamines with no family history. So I guess this is, do you investigate all these patients, and do you offer them some of these new lovely drugs that we've been describing?
Well, we can't offer them the new drugs, sadly, because they're not commissioned for us in the UK. We like investigating them, but we have very limited access to genetics in England, especially Scotland. I think you're doing a lot better in Scotland in terms of genetics you can do. Because these are the other genes are quite rare, to be honest with you. But we would love to and like to try investigating them. There is a study going on at the moment in Berlin. We try and link them to that study. As I said, we can't give them these fancy drugs,
Is there
sadly.
any evidence base for giving them if you weren't constrained by finance,
There
shall
is
we say?
there is some evidence, and there's some evidence especially for bradykinin receptor antagonist icatibant, and we are actually doing an emergency commissioning for England that hopefully, I don't know, we are kind of final stages of it at the moment, and we'll see what happens. If that commission comes through, at least they can have treatment for their acute attacks, because there's nothing for them at the moment.
Okay, and can I ask third question from Mary Keoghan, who's asking if patients become attack-free on, for example, lanadelumab, do you still encourage them to carry rescue medications? And I also wonder, would you allow them to have their tooth extraction without prophylaxis?
That's a difficult question, Mary. But because the studies haven't been done, I can't really talk about it here. I can't really say. I know people have gone and done things without telling us, without taking prophylaxis. I wouldn't be able to say to them not to have prophylaxis unless there are studies to prove that. But in terms of carrying acute medication, it's the same thing. But we all know patients will do their own things with time and experience. But potentially they have a disease which can sometime come back depending on the level of stress or physiological. So I think I wouldn't feel safe enough or comfortable enough to say, no, you don't need to take any other precautions.
Okay, can I just ask our moderators, do we have time for any more? I have a quick question from Charu Chopra. Do you still have patients on long-term danazol or anabolic steroids, and are you actively switching them to something else right now?
Well, I do have a few, not many. I give them the information and I leave it to them. I know some who are incredibly attached and don't want to change, and that's fine. I just have to keep monitoring them because you have to really regularly monitor them, as you know. But I've had patients who've gone and read the information, come back and said, oh, I didn't know this was a side effect of that. I didn't know poor sleep was, anxiety was. I didn't know my hirsutism was. And they've come back and asked for switching. But I don't feel nowadays, with the level of evidence available, one could not discuss it with the patients because I think there is an ethical issue there.
Not to mention a challenge of obtaining the anabolic steroids these days.
Yeah.
One last question from Frederick Kanyeki. How do you manage HAE during pregnancy?
With C1 only, still. And acute attack C1 if they need prophylaxis and they reach criteria C1. And probably best to use plasma concentrate. Although I know people who couldn't have that, who had sort of a clotting history. We used Ruconest in the past on named patient basis because of a relatively safer option as there are no trace clotting factors.
And at the other end of the hormone spectrum, what do you advise in menopause? Do you suggest avoiding HRT, or do you think that's okay
No,
for
not
HAE
really. I mean,
patients?
there was a sort of a good discussion, and so people were talking about it. I think Patrick Young was one who found a lot of literature around. One of the things is that it seems to be different people respond differently. Obviously, estrogens are meant to be avoided, but there isn't massive evidence on HRT. The thing is, we recommend Tibolone, which seems to be as an HRT, which seems to be tolerated by patients with hereditary angioedema. But many patients with hereditary angioedema can also tolerate other HRT. It seems it doesn't change, but if they start on it, often started by somebody else, and you didn't know about it, they come and tell you, and it seems to not change the number of attacks, then you probably better leave it.
Okay. On that note, we had better finish. So thank you so much to Serena for such an enjoyable presentation and taking the time to answer all our questions. And thank you to all our participants for joining us today, and those who might join in the future looking at the recording. Thank you very much, everyone.
Thank you, Mara.